Welcome, everyone. Thank you so much for joining our MOPA Integrated Care Committee. My name is Dr. Robin Lute. I'm a licensed clinical psychologist working at Compass Health, and I have served as a behavioral health consultant in the past with my distinguished guest, Dr. Leslie Manson, who will be presenting with us today, and I'll allow her to introduce herself. I want to go ahead and make a few quick announcements or talking points. Firstly, please let me apologize for the delay. We've done a fair amount of these and we tend to get them right 99% of the time. We just had a little bit of a technical snafu this morning. So hopefully we'll still have plenty of time to have a robust discussion and to enjoy the time that we can spend together this morning. So as a reminder, this is a discussion, not a seminar per se. So while Dr. Manson and I will lead the discussion and provide some information, certainly it's a more enjoyable time, and I believe we all learn a lot more when everybody chimes in with their experiences, their questions. So while you'll be generally muted for the sake of everybody being able to hear, please feel free at any time to unmute yourself. There is a chat box that if you don't feel comfortable speaking out loud, we do have a chat option. And maybe Chuck, do you mind monitoring that? If anything relevant.
That's fine. I'd be happy to do that.
Thank you. Thank you. So you can turn off, like I said, your own video, your own audio on and off as you need to, if you want to jump in, especially if you want to ask a question or add some of your experiences. And you may have agreed when you signed on to note that this is being recorded. So please know that we're being recorded, and this may be used for possible future events or education through the Missouri Psychological Association. Everything that will be shared today between Dr. Manson and myself absolutely represents our views and opinions and not those of MOPA. So it's my pleasure to be here with you this morning. And as I said, we have a special guest with us, Dr. Leslie Manson. So I'm going to kick it off to you, Leslie, and ask you to please introduce yourself, and then we'll get moving.
Great. Thank you, Dr. Lute. Can everybody hear me okay?
Yeah.
Oh, wonderful. Thank you. So hi, everybody. As Dr. Lute said, I'm Dr. Leslie Manson. So greetings, everyone. I'm coming to you from sunny, although you can't see it today. Here at Arizona and Arizona State University. I'm a clinical associate professor here, as well as the director of the Doctor of Behavioral Health program, which is actually a retraining program for clinicians who are licensed to actually re-enter into integrated care workforce. And in addition, I'm also the chair of integrated initiatives, and I run a Project ECHO for integrated care. I have numerous publications on integrated care and in specific financing and fiscally sustainable team-based care. I actually have some presentations and publications with Dr. Lute as well, whichever direction you're sitting on with me next to me here. And my background is that I've spent almost about 20 years now in integrated care in various types of positions as a clinician for many years, as a behavioral health provider, and then also as a site administrator in federally qualified health centers, as a director, and then as a member of the executive officer committee at federally qualified health centers. So my experience kind of spans different levels, and all through that, obviously, still providing direct care. And so that's a little bit about my background. And thank you so much for inviting me today to talk a little bit about the models and exploring it.
Thank you so much for being here, Dr. Manson. So as you all can see, my best friend knows a lot, and so we're going to take advantage of her today. Okay. So again, many of you may have some experiences that you want to share. Dr. Manson and I both started with integrated care quite some time ago, as she mentioned, working as BHCs way back when. So just a quick, for those of you who may be new to integrated care, coordinated care, interprofessional care. We'll talk a little bit about some of the different terms that are used and how they differ. Um, as you may know, whether you're skilled or schooled in these particular models or not, in the distant past and still in some areas in our country today, care is very siloed. So when we're talking about healthcare, wellness, whole person care, it tends to be still different buildings, different processes, different pathways through the system for different types of healthcare, so that you may show up at your primary care physician, receive a referral to go see a psychologist who is in a different city or down the road or in a different building, which tends to contribute to people not following through as much. And we'll talk a little bit more about some of the improved access with integrated care. A handful of years ago, I guess it's been several decades at this point, we started moving into the recognition that team-based care, interdisciplinary care, is a more effective way to address the whole person. And given the strong overlap between individuals who, let's say, have chronic health conditions as well as a mental health condition, and then therefore have more challenge taking care of their physical health, the inverse also happens, where if somebody has difficulty taking care of their mental health, other pieces of their life are going to fall off. So there's been this movement towards recognizing that not only is it better care for individuals, many providers are more satisfied working in integrated teams. Many clients are very satisfied, and there tends to be a lot of cost savings. And so Dr. Manson will get it more into some of the newer legislation that has been proposed for APA around cost per se. So over time, we've started moving into this idea that maybe we could at least put people in the same building, right? And depending on what type of model we're talking about with respect to integrated care, I think it's important to keep in mind that these models can exist on a spectrum, right? Just like so many other things in our field, where maybe we're talking no collaboration between, let's say, a physician and a mental health provider on one end, and then on the complete other end of the spectrum would be those providers actually sharing a pod space where they work together, they see clients together, they plan treatment together, and then everything in between. Okay, so maybe co-located care in the middle, where different types of providers are in the same facility. They may not be located in the same place, but they can talk through their EMRs or their EHRs, etc. So I'll pause there for a moment. I'm going to ask Dr. Manson, did you want to add anything about, I'm giving a very obviously loose history. And again, anyone who wants to jump in and add to that, please do. Would you add anything, Leslie?
Actually, yeah. I mean, first, I just wanted to kind of ask a question to see if anybody out there is able to turn on their microphone or maybe place something in the chat box. But I'd love to see how many people here are working in integrated care settings right now. Are there many working in there? And if so, okay, so Paul, and if so, what model of integrated care are you using? There's actually a core set of operationalized models. However, a lot of people just kind of get together, right? And just do like a team effort and may not actually do one of the operationalized models. So just checking in, does anybody have a specific model you're using?
Hi, this is Dr. Winston. I am currently working at Compass Health with Dr. Lute, so I was so excited to be participate in this call today. I may have to run if my client pops in a little bit late, but I previously, before I joined the team here at Compass, I was the director of behavioral health at a federally qualified health center on the Kansas side in Johnson County, and that model followed kind of the Cherokee Systems model, which I'm sure you're familiar of. So it was a completely integrated behavioral health program within the primary care and dental settings. Before I left, we had just added substance abuse services and we're attempting to add therapy services, but our behavioral health, when I was there for the past 2 years, was just BHCs in the primary care setting. So it was completely integrated. We had great collaboration, and we would have to refer out for additional kind of psychiatric care and services. But we were starting to expand to include psychiatry via telehealth on site, and start to offer some limited therapy services. And then we started our SUD and MAT program as well. But as far as the primary care setting, it was completely integrated behavioral health, BHCs.
Perfect. So I'm just going to kind of give a little bit of another kind of reference just for those of you who are out there listening and they just heard what Dr. Winston was saying. She's talking about the Cherokee model. Now the Cherokee model, and that's with Perinda, and we've worked with her, actually, Dr. Lute and I have previously. So what that model is actually the primary care behavioral health model, or what's referred to as the PCBH models. For those of you who are on, that is one of the standardized operationalized models. And it is one of the models that's actually written into federal legislation that give actual medical sites additional value-based money for putting it into care. So it's actually also written into MACRA in specific. So it's great. And that's Medicare plans. So just so folks know. And also what she's referred to is other types of programs like substance use programs or OUD programs. All of those actually are other types of what we call kind of vertical integrations that are coming in. And so if there's specialized integration programs that come into medical care centers. So that's great. In addition, it sounds like she was also kind of moving toward, or maybe the clinic ended up moving toward what we call either CCM or COCM models, which are care management, or collaborative care management, which has a psychiatric component on it. In addition, a lot of sites may not do that specific model. They'll just do a psychiatric model where they'll add on a psychiatric provider to provide direct care. Whereas conversely, the COCM model, which is the collaborative care, that psychiatrist does not have to ever interact with a patient. It is purely consultative. They do have to interact with the care manager weekly on every single patient that's billed. So it has to be weekly consultation, but they never see a patient. So there's no requirements for that. That's not part of the model at all. So just to kind of distinguish a little bit in that. Dr. Court, if hopefully I said that right. Do you want to
or T, long E.
I was wondering, I was like, oh, do I say it?
Yeah. I'm in VA, so we have primary care mental health integration, which is very much like PCBH, as well as the collaborative care model component to it. So.
Yep. And where are you? Oh, you're in Kansas. Where are you located?
Columbia, Missouri.
Columbia, Missouri.
Yep.
Yeah, thank you. Yeah. I've got some great friends. I know Dr. Lute does too, in the VA and the DOD, and working within those models. So those are actually exemplar models. So it's great to have that. And as far as like thinking about PCBH and how that's been going, that's been almost 70 years now within the Department of Defense. So just for folks to know, these models are well established, and the World Health Organization, now it's over 70 years ago, has actually said, this is what we should be doing. And then every 25 years or so, they put up a new statement saying team-based care is where we need to be. So we're still working toward it, although all of us in it are like, yeah, we've been doing this as old hat. But for most places, this is very new. So very understandable. Anybody else want to share?
Dr. Manson, I just want to jump in for 1 second. You mentioned that. I think for those of us who are familiar with integrated care, have had those experiences, have seen patient satisfaction and client improvement, it's almost like the default for those of us who had some exposure to it. And this is anecdotal, but it's real. It's my anecdote. I was seeing a client yesterday who has 4 different providers, whether it's PCP, psychiatry, cardiology, etc., and not one person is managing all of her medications, right? So we had to have a talk about updating her med list, taking it to her primary care physician, even with the idea that he was saying, well, Prozac is not something I manage, that's what your psychiatrist manages. Well, we still need you, doc, to know that, to know the side effects, to keep that on your list. So it's just, like you said, I think some of us know so much about the benefits and have been in it that it's almost shocking to see systems where they don't have at least interdisciplinary care or multidisciplinary care, right? So there can be that slight well, not slight, there is a difference between interdisciplinary and multidisciplinary and collaborative. So there may be centers that we work in where, yes, there are different kinds of providers within the system, and yet they're not working together on a treatment plan per se. They're still siloed even within that system. And so there may be some additional consultation, but it still doesn't get to that fully. Everybody on the team is going to contribute their expertise to how do we best help this client.
I would say that's very true. And that's kind of a barrier systematically for integrated care a lot. And some of that I'm going to reflect upon is part of kind of team building. Just because you put providers together doesn't mean that we work together collaboratively as a team. I know the VAs hit some of that before too. Just because we're all working there and we have aspects of that care and we even communicate with each other, it doesn't really mean that we always hear each other, read it, and then actually kind of work with the patient in that way. And so sometimes that step is missing. And that's kind of like what Dr. Lute was just saying, as far as that, right? Interdisciplinary, multidisciplinary, how are we actually working together? And even if we are spread apart or all together, we really have to look at specific models and our structure and what we do and operate as a team and how we work with a patient, view a patient, and interact with a patient. And that patient needs to be part of the care team ultimately, and obviously as well. So they need to have their voice heard with all of those providers or those people doing that. In some places, they actually assign a care manager whose pure role is to do that, right? Operationally, is to actually go and consult and bring it all back and talk with the patient about that, bring it back to everybody again. And they're constantly digesting and documenting all of that. In other places, it's the team getting together through huddles and other types of kind of reviews daily about patients and making sure we're operationalizing it through those models of integrated care. But it is tough. I'd love to hear, are there certain challenges people experience with integrated care that you recognize? Maybe it's something that you want to bring up of just like, yes, we do it. Or maybe it's something that that maybe being in this spot right now with everybody on, perhaps you can get some different types of experiences or help to make improvements in that area. Anybody have items or barriers or challenges they've had?
I think one thing that was interesting, we don't have so much of this problem anymore, but I know when I was hired here to kind of get PCMHI off the ground, what was interesting was we got more pushback from mental health than we did from primary care, which I thought was quite intriguing. Very much this idea that this one model, this is the only way we do mental health, and us having to kind of have to push back and say, no, we're not going to ask about, all their educational history because we don't have time. That's not important. We're the here and now and not all this other stuff. And so kind of having to have mental health kind of had some growing pains with myself and the other psychologists that I hired at the same time with that, because it was this idea that a 30-minute visit and you only focus on here and now and don't collect all this history, that's just not mental health, and you're failing, you're doing something wrong. So having to do probably more education with mental health than we did primary care. I think primary care was probably just relieved to have help.
I would say
I would like to second that.
Yeah,
Absolutely.
I was going to say, I think we're all going to jump in on what Dr. Cordy's saying, but go ahead, Leslie, I'm sorry. And then Dr. Winston, I'll wait my.
Yeah, Dr. Winston, go for it. You go first.
I was just going to say, I was newer to the model, coming from most of my training and schooling and background was in addiction medicine in Southern California, the rehab Riviera, as they like to call it. So I came to the Midwest and was in Kansas and learned about this model when I was being recruited for some positions out here when I was moving. And I didn't know how we hadn't been using it. So it was new to me. And I'm like, this is the only way to work. This is amazing. And as I was the director and hiring staff, I found in mental health professionals who were unaware of this model were a little bit more resistant. 16 to 20 minutes, there's no way. And I was training new staff and really trying to help them consolidate the visit, understand what the goals were, and that they weren't there to do a therapy session. They weren't there to get the entire backstory. What does that integrated visit really look like and what's the purpose? So I would agree. It was interesting. I felt the same support, thankfully, from the primary care and medical side and dental side. They were just grateful to have somebody there. You know, they didn't know how to ask people about depression or suicidality. They're mandated reporters and didn't know how to handle that and would always come to us. So I think they were really grateful to have that behavioral health support. But I think, yeah, I found it was a really interesting experience where I personally didn't have that. I was thrilled. I thought it was a great change. So I think overall, I think it's a transition for a lot of clinicians.
Dr. Lute, want to go for it? I'll go last.
I don't know that I'm adding anything new. It just, you know, I'm thinking, Dr. Corti, you must be really popular when you first arrived at the Columbia VA with the mental health individuals. And I agree with all of this. It's a different way for us to conceptualize how to be healthcare providers, right? So even with our terminology, you know, we don't say we're mental health consultants. We say we're behavioral health consultants in like the primary care behavioral health model, right? Because we're talking about addressing substance use issues, we're talking about medication adherence, we're talking about behavior changes. We do address mental health, of course, but the terminology reflects a different approach, a different skill set, and for individuals who have been primarily and maybe for years thoroughly trained in that 50-minute don't you dare interrupt or knock on my door model, you're going to have a really hard time shifting potentially, because this type of model requires a great deal of cognitive flexibility, and for you to be working on one thing and to be interrupted to go pull on, you know, to work on something else, much more like physicians are used to, you know, somebody knocking on the door, them having to step out, tell the client I'll be right back. And clients, we tend to have a little bit more hesitation around it than clients do. So the more normalized we are about, I'm going to step out for a moment because this is a team situation, I think the clients read that from us. And then the last thing I'll say, Dr. Corti, to your point, is that idea, and I think Dr. Winston, you mentioned this too, that, you know, the medical dental providers are like, yes, please come, yes. And, you know, evidence has borne that out. So while we've all had that anecdotal experience, you know, research around the quadruple aim has showed that provider satisfaction, increased provider satisfaction, is one of the benefits of integrated care. So just for those of you that aren't familiar with the quadruple aim, Leslie, do you want to jump in on it? Or I don't mind going through it, but I feel like I'm taking over.
No, certainly. So for the quadruple aims, those are kind of things that we look at a lot in academia or federal governments. But really it's about best practice for folks that are clinicians and really working in the field. So what we're looking at is, one of the aims is to make sure that our populations have the highest satisfaction. Another one is that our populations have basically really good outcomes. Another one is to look at making sure that we're actually fiscally responsible, really, with our money and how we're operationalizing healthcare in various ways. And then that quadruple aim is making sure that really ultimately our team is satisfied, because that comes from the Bodenheimer model of, hey, let's wake up. If we're not healthy, you know, and we're not really satisfied, then we really can't provide good quality care to our patients. And so that's where that comes from. And there's a lot of research backing the quadruple or the triple and quadruple aims of healthcare. And that comes from the Institute of Healthcare Information, I believe it is, or something like that now.
It's the IHI. It used
to. Yeah, they just changed something in it too, right? Yeah, it's like, who are they now? I think it's really normal, right? I was a master's level clinician, I think in like 98, 99, you know, and then became a psychologist after that. And during my entire time, I wasn't taught integrated models at first. I did my internships and residencies in them and as a psychologist. So there you go. But really, you know, at first, when I was first practicing as a master's level clinician, that's not what I learned in those early years, right? I learned this kind of 50-minute model, but if we think about it and you look at it, it's not actually a model. So, some of that I had to actually step back because I kind of had this ownership of it, that this is what I needed to do. Right. And I felt like as a practitioner, that's all I knew. And there was days where it was challenging to actually end at 50 minutes with patients. Right. And now I've seen patients for 15 minutes and had lasting outcomes. Right. And the PCBH outcomes and the outcomes for integrated team-based care, so including like care management and COCM and all that, really demonstrate long-term outcomes of brief evidence-based interventions for 15 to 30 minutes that actually last for patients that actually have either, it can be just kind of brief psychological or mental health care needs to serious and persistent mental illness. Okay, that the outcomes have lasted over 4 years with only 4 visits for integrated care. So the evidence is actually pretty big, and articles continue to roll out ongoingly. The more people are actually getting into the strict use of the models, because the strict use of the models have only been about 20 years, maybe 22, I think it was in 2000 was like when the really strict use of the models started. So we're really gaining that evidence. But just to kind of do that shout out, I think it's really common when we're a mental health provider to have that disruption of, wait, this isn't right, and then be challenged personally and professionally to go, oh, wait, what does my own evidence show, right? Because I had to go in and challenge myself with, what does the evidence show? Where, does it say that this is needed? And in fact, there's a large amount of evidence worldwide that indicates that the longer we spend with patients, the more likely we actually are not going to be helpful, or we can actually reverse in our helping in the visit. And so that's where those changes came, even with our times as mental health clinicians worldwide. They changed our times. It used to be 50 minutes. Everybody remember that? And then they changed all of them to that 30, 45, right? On up models, as far as our billing codes, even it came from all of that evidence. And it came from all of the evidence of what we look at as far as, if you want to look at evidence-based care, and you go to the evidence-based care websites, right? You can look at all of those practices. And if you're doing an evidence-based care model, then you're going to have to do it to that specific degree of time and frequency and duration. And there's a slew of models and information about time-based interventions, and how even with some symptoms and behaviors, just doing something like a minute of an intervention has a statistical change. So thinking about smoking cessation and talking about it for purely 1 minute. So it's really important to actually go in and dive into the evidence, even for folks like looking at treatment for things like schizophrenia, schizotypal, personality disorders, major depression, bipolar, as well as, our complicated or comorbid conditions where we're looking at diabetes and depression, right? And how they interlink, we're looking multifaceted related to things, even with PTSD and trauma. There's a lot of evidence related to looking at it with time and looking at smaller amounts of interventions, very specifically geared, and then having that break and then doing it again later. So not exhausting this large amount of time in one session with a patient. So I just kind of like want to normalize, it does take us as clinicians to actually go out and go, wait, I learned this, but there was no evidence when I learned it, because I had to go back to my textbooks. It wasn't based in evidence. There are some evidence-based models related to psychoanalysis that are very specific, that require that, and some very specific evidence-based interventions. But outside of that, the majority is actually less in time. So it's interesting, right? Those are just things that we lack in education and training sometimes. And I think that's where, too, as professionals, it's really important for us to do more of this, that we talk about it and we actually challenge ourselves, and we help to really re-educate ourselves and actually push out to more and more psych programs, marriage and family therapy programs, right? LCSW social work programs, professional counselor programs are actually looking at this and bringing in more of these models and really teaching aligned with the evidence and showing, here's one way, let's practice that model. So these are the models, and let's practice it with a longer amount of time. And then for these patients with this, these are the models that would be better with shorter amount of time. So we have those dueling experiences, right? Because back in the day, we didn't get that.
We were showing our age, Dr. Manson. So there may be people on here who are like, I don't know what you're talking about. I taught integrated care as a professor. So I want to jump in on what you said regarding evidence and just take it in a slightly different direction. You'd made a mention earlier of the clients participation. And so most of us probably know this. I think it is worth a shout out, a reminder that current evidence-based medicine, evidence-based care requires the client's participation meaningfully, in the sense that I mean, of course, we don't force interventions on anyone. I am referring more to the idea that the client is asked and allowed to bring their culture to the situation, their decision making around what they would like to focus on, and have their values, their resources, their abilities, their desired outcomes as part of the treatment. That, again, even if we're working as an integrated team, we don't just decide everything that's going to be good for the client or the client's family. We need to bring that person in to really to participate very actively and to have their voice heard. The other piece of ethics that kind of pops up for me, or evidence, is kind of thinking a little bit about ethics and how, and sometimes we can get good stories with this, that, when we're co-treatment planning or making decisions about documentation, or even thinking about mandated reporter status, if you are, let's say, an LCSW or a licensed psychologist, what your ethics board may say, what your local or state agencies may require from you ethically, can look very different across professions. So there is some work that needs to be done if you're on an interdisciplinary team around the fact that maybe a physician is going to respond to a given situation differently than you may from an ethical standpoint. Has anybody had those kinds of experiences where you've kind of had to work with the team and say, oh, I want to be available, but as a psychologist, I can't do that. Maybe the physician can do it, or vice versa. Does anything come to mind for those barriers? I mean, one of the things I immediately think of is sort of mandated reporter status, whereas I can speak for licensed psychologists, we do not have to report suspected spousal or interpersonal violence, whereas physicians are supposed to. It's just an idea of what comes to mind. So, how do you work around that? Dr. Cordy, did you unmute?
I was just going to say that I can't come up with something on the top of my head as far as where it was like completely inappropriate for me to do, but there was a lot of conversations to say, no, you need to do this, that I'm not the dumping ground, and whether it was like a mandated report, obviously it's the person who finds that out. They're the ones who have to make the mandated report. You don't get to pass that off to somebody else. But also, sometimes I had a physician who tried to push something on me. It was basically an observational type of assessment, and basically told him, I said, look, this patient is gonna have to drive all the way here for me to do all this stuff. You already know him. You need to do this, not me. So some of that kind of boundary setting to assure that the mental health provider does not become the dumping ground.
And I wanted to second that. That was kind of my experience. I think especially not so much necessarily with the medical providers, like our pediatrician was very capable and competent of making those reports. I'm sure was very accustomed to having to make child abuse reports. Unfortunately, our dental staff that would encounter things immediately would just kind of back off and try to come to us to do that. And we'd never met the client. We weren't involved in the situation. It was all hearsay. And really kind of coaching them through the process, saying, you met with the client, you're also a mandated reporter, you saw the visible whatever that led to concern, you're the one that needs to do that. So educating them and kind of coaching them and supporting them through it. But yeah, I think that initial instinct is, behavioral health. Same thing with some of the nurse practitioners that weren't primarily pediatricians, but would encounter a reporting issue, would immediately, well, you did an integrated visit, you need to do the report. And I said, no, yes, I can help support you, but that's not my role. You're the one that was making the observations and suspecting, your concerns. You need to share your concerns. So yeah, very similar situations.
Yeah, I know I've had similar situations as well. I know Dr. Ludis too, and we've actually spoken on ethics before. And um, I think it's really important, right? We all know that it can be really anxiety provoking to do that reporting, especially when you first start that activity and you haven't done it a lot often. Like most of us have probably it's like, yeah, we've done it all the time now, and we have our systematic way that we do it. But for those in medical care, often they actually don't have that experience, especially if they're new or they've been in care and they just aren't asking those questions. Some of that comes from their own anxieties related to that. And sometimes it's about scope, that they don't feel that they're competent to actually respond in a way that's going to be beneficial for that patient. And so sometimes there's some purposeful not, asking. Now it's generally mandated to ask certain questions and to do certain types of screenings and all that. But just to kind of back up what everybody else is saying, I've had a lot of mental health practitioners, both from colleagues and friends to also students at times, that have this belief that mental health practitioners, we report a lot more than those medical. And it's actually not true. We actually have more restrictive reporting laws than they do. So medical providers actually report more than we do. So it's really interesting when I hear that, just to kind of let people know it's actually that they report more often. They actually have more reporting requirements than we do.
Right.
So.
And I think just taking a kind of a step back and looking at the kind of meta perspective of this, I think I hear a lot of education. I think these roles as whether you're a behavioral health consultant or whatever that title may be in a given facility or model, a lot of this is education, not just for the client. Often we're educating and supporting providers in different ways, MAs, front desk staff, kind of, I don't want to say jack of all trades, implying that we go out of scope, but I don't know, kind of everywhere. We're everywhere in this model, so that we do obviously see a lot of clients and yet provide a lot of support for other individuals as well. And, I don't want to, maybe I'm beating a dead horse with the ethics. I think there are different expectations among different providers. Like mental health providers tend to have very strict boundaries. So for instance, let's say I'm, really sick of the pandemic, just hypothetically. Let's say I'm really annoyed and sick of, the fact that people won't behave and wear masks. Totally hypothetically, I would not go to Dr. Manson other than to vent and talk as my friend or my colleague. I would not go to her for, let's say, an adjustment disorder or treatment. Whereas physicians, other PAs, other healthcare providers will consult with each other and will prescribe for each other, and that's not against their ethics. And so it brings up, again, additional education interactions where sometimes we're saying, I can talk to you for a moment as my colleague. I can't really see you for your burnout regularly as one of my behavioral health clients. And sometimes other professions don't understand that. I'm here, I know you, I'll feel most comfortable with you. And, one of the reasons we do this co-located integrated care is to increase access, right? We're trying to reduce inequities and we're trying to increase access. So if we think about some of the social determinants of health and how those can impact on a given individual's literal lifespan, quality of life, etc., one of those benefits of being co-located is increasing that access to care. So, if you're working alongside a physician, it's like, we're both right here, or you can't talk to me, and being able to have to explain and kind of go through, here's what I can do, here's what I can't do, because our ethics and expectations can look different. So we're constantly learning about the different disciplines that we're working with and how do we best work together. And as I mentioned, the social determinants, one of the things, for those of you that are maybe not familiar with that kind of concept, we're kind of refers to literally social, economic, help me out here. What am I missing? Financial, where you're living, just all of these biopsychosocial factors around a person that can really directly influence their health. So for instance, Dr. Winston and I work in a rural clinic at this point, and we all know that rural populations can have a harder time accessing care for lots of reasons. There's fewer providers often, maybe in certain areas. Dr. Manson, when we worked in a very, very rural area together, it was almost a frontier level environment. And, if there's one licensed clinical psychologist there, again, who do people go to? How does that work? Increasing access to the behavioral health side, if clients can get to their primary care physician and then have additional supports right there in the office, or maybe asynchronously through telehealth or live through telehealth options, we can really increase the quality of care.
And some of that, like Dr. Lee was just saying, is just being in proximity. We know that when you trust your medical provider and they make a recommendation, if the person's in proximity, that trust actually goes with them and they're more easily able to go to see that person. But if they have to go down the street, they have to call their insurance, they have to, drive, make appointments, do all of that, the likelihood is actually very, very low. When they've done auditing of medical providers and different types of specialty medical providers sites, they find that really it's between this 10 and 30% of patients actually follow through with referrals to psychological and psychiatric
so
care.
low. It's so low.
But when we're in-house, it's like 70 to 90%. It's like a crazy, crazy difference, regardless of the model, really. So it's a really good thing that when we start to looking at working as a team. I'm wondering, does anybody have questions? I know we're actually getting low on time, related to the models or related to funding. There's different types of billing codes related to the models, different ways you do the models. And there's actually a lot of legislation that supports the models. I had noted, I just kind of flagged it a little bit earlier, in specific, the COCM model and the PCBH model has been written into legislation multiple times. So legislation has passed the models for MACRA, for value-based care. But in addition, there's different legislative efforts that have actually spurred COCM, that's the Collaborative Care Psychiatric Model, to have further support within the federal legislation and to provide different types of grant funding. So for those of you who might be familiar with things like CPC Plus, and now it's Primary Care First, CPC Plus is gone. But for years that rolled out money for states, and all of that money was actually for them to hire behavioral health providers for different types of medical or specialty medical centers to be able to bring on a level of integrated care. But they had to choose one of those models. They had to choose either the COCM or the PCBH in specific. So there was actually millions upon millions of dollars going out to really support these models and move them out. And there's new legislation coming up this year in 2022 that's already been proposed. The American Psychiatric Association has put a movement forward to push their COCM model even further with more grant support, more support by the federal government, and to roll it out further to move psychiatric clinicians and their consulting more into generalized care and specialty care in the United States. They've actually had some folks, I did some testifying with legislators related to it for American Psych Association, I should say, the other APA related to it. And they actually worked with APA and have actually changed their legislation proposal and added in the PCBH model to it now. So they say it's a both model. So they either could do the COCM and get more money and keep it moving, or they can do the COCM and the PCBH model. They're still in negotiations. They're hoping before that legislation launches that it will be either, so that people can actually choose based off of what their patients and community needs are and what they can hire for, right? It's very hard to find psychiatric clinicians, not that it's not hard to find mental health clinicians. It is still, but not as difficult. And so there's a lot of reasons related to that for rural health and other types of healthcare, so that we can actually be able to provide more healthcare. So there is legislation currently pending and moving forward, as well as more related to care coordination. And if folks don't know, even health coaches, that legislation pushed out, like I want to say 5 years ago now. It's got 2 more years to go. Health coaching and health coaches now, if they're certified, can actually do billing, pure billing, as long as they're in a medical model. And they can do billing and get reimbursed for their services as long as they're certified. So that is not someone who has other types of licensures or education. It is someone who has the health coaching certification. And that's going to go up for review in 2 years. And I'm sure all of the psych associations will be looking at that and adding their information to those legislation as well. But there's a lot that has been rolling out, especially with peer supports and other types of kind of movements for mental health treatments. So just to kind of be aware of where legislation is going and how you can work with your psych associations related to your viewpoints, and also making sure that we keep our professions and our scope very relevant too.
Dr. Manson, I'm going to jump in because, as you said, we're getting close to time. And, I want to thank everybody for spending time with us this afternoon. I think we wanted to include a little bit more of the pros and cons and descriptions of the actual different models themselves. We lost a little bit of time, as we mentioned earlier, kind of getting all of us on the same Zoom at the same time. So, like so many of the topics that we bring up here, I feel like almost any of these individual threads that are discussed could in and of themselves become like a full seminar. So please feel free to reach out to myself, to MOPA, if you have ideas, future topics, things that you would like to see, maybe things that you would like to present on from an integrated care perspective, whether that's or be a panelist. We won't just throw you out there to the wolves. Not that the rest of you are wolves, you know what I mean. So that we can really take as much advantage of everybody's specialties and knowledge. So I do want to mention that on January 19th, so not too far in the future, MOPA will be holding a webinar for pediatric obesity. And again, these webinars, if you are a MOPA member, you do get a free CEU. So everybody's allowed to come for free. But if you're a MOPA member, you can go ahead and get that free 1 CEU. And these discussions, every other month, you receive a CEU if you would like it, 1 free CEU. So when we do our February 3rd, so go ahead and mark your calendars now, Integrated Care Roundtable, that one will include a 1-hour free CEU. Again, as you know, these sessions are recorded, so all of the roundtables that we've done thus far are available through mopaonline.org. They are both our webinars and these kind of seminars, roundtables are available in the archives. So certainly feel free to visit those if you want to look for a specific topic. I know we are going right up to that minute, and most of us probably have clients or meetings or students waiting for us. So I really want to thank you all for coming, for being a part of this discussion, for showing up and supporting us, and for helping all of us continue to work toward our shared goal of improving our healthcare system, improving our outcomes for our clients, improving our own satisfaction, and keeping things affordable. So thank you all so much for being here, and hope to see you on February 3rd, if not January 19th, for that additional pediatric obesity seminar. So make sure you check MOPA online. Okay. Does anybody have any last minute questions, thoughts, additions? All right. Well, again, thank you for being here. Thanks for joining us, Dr. Manson. It's good to see everybody, and I hope to see you again.
Thank you.
Bye-bye.
Bye.